That relaxed me. Amazing. Steve, thank you. Thank you for that kind and generous introduction and roast. I mean, it's such an honor to be here. It's one of the highlights of my career, so thank you so much for having me. And I want to start by just saying this is the talk. A vision for continued growth. Are we doing our best? And these are my financial disclosures. But what I really want to talk about is, look at the past lectures. I'm so humbled and honored. I look at this group, and these are all my mentors, my heroes, and a lot of my friends and colleagues, and it's such an honor to be listed amongst them. I want to talk a little bit about my personal background, talk about the gift of failure and a growth mindset, and then my motivation for innovation. And I'm actually going to introduce a new surgery that we've been developing at GATT. And then I'm going to also challenge us to redefine our definition of success. But first, I want to kind of give some early background, not the background Steve Getty gave, but these are my parents, and they're here in the audience, and I'm the son of immigrants. My parents were born in India. They immigrated via England to the United States. My dad was a dentist in India, and they arrived actually to DC, about 10 miles from here, in 1973 with a daughter and $300. And they cleaned toilets, worked overnight. My dad finally got certified to practice in the United States, and he actually joined the U.S. military to serve the country that welcomed him. And he served honorably for 28 years as an officer. My mom completed Culinary Academy as a chef, and we moved around the world every 3 to 4 years, and got to see the world. And ended up in high school in Germany, and then my life path took me through California at UC Davis, and then Baltimore, and then, what's crazy, Steve, this is 15 years ago. Steve Getty does not age. He looks exactly the same. It's just it's absurd. So this is the closest I've ever come to greatness, is the moment Steve Getty wore my name badge. And I think I'm never going to attain a peak that high in my life. And I've had just a tremendous group of mentors and role models, and I'm so humbled to have that with my team at Wilmer at the time. Dave Friedman was such an important part of my life, and Harry Quigley, Pradeep. I did my very first SLT with Gail Schwartz, and then the Bascom family, one of my favorite mentors who's taken from us way too soon, Francisco Fontes, and the entire crew. I was so fortunate to have so many wonderful mentors. And then in 2010, this was the Glaucoma family that welcomed me in 2010. And I found a private academic practice that allowed me to innovate, that was supportive, efficient, and was busy. And I was able to learn, to practice, to do research, to teach, and to create. And this Glaucoma family has just blossomed into what we have now. And I could not imagine practicing without them. They are my emotional support group. They pick me up when I fall down, and they motivate me to be a better doctor. And it's all because of this gentleman in the middle of that picture, Ron Fellman. So, in Glaucoma Associates, you spend your first year basically doing what we call the Ron Fellman Fellowship. I'm in the remedial fellowship because I've been doing that for 15 years, so I'm a PGY 20. And Ron Fellman has just had such a tremendous impact on my knowledge of glaucoma. He is just overly generous with his time, with his knowledge, and he has this insatiable desire to learn and to teach, and it's palpable and contagious. But what was crazy is he was actually my invisible safety net. I didn't realize it, but he was my invisible safety net, which allowed me to try new things and also say it was okay to fail. And that really got me thinking about my path to growth and these two books are very instrumental to me. One is The Comfort Crisis, and two is The Gift of Failure. Comfort Crisis talks about how, we have this innate desire to kind of seek the path of easiest resistance, where we kind of living in a state of underactivity and overnutrition. But if you seek discomfort, it will make you stronger and better and healthier. And then I initially read The Gift of Failure to try to be a better dad, and how am I going to help raise our kids and let them learn from their failures. And then I was like, wait a minute, that's what Ron Fellman's been doing us the whole time. And so I seek to be comfortable with being uncomfortable in the operating room. And really, Ron has given a gift of all the glaucoma doctors of that gift of failure. That first time you have your choroidal hemorrhage in a monocular patient, he's like, well, one day I had 2. And he just picks you up off the ground. And like, if someone's been doing this for 43 years, it makes you feel a little bit better and helps you carry on and still believe. And so what's interesting is, GATT, that's actually came from a story of failure. So Ron Fellman, you can't get a gonioprism out of his hand, and he was in clinic one day staring at a patient that had a prior trabectome. And he was looking at that trabecular shelf, and he was like, I think I can get a suture in there. So he doesn't tell us anything. He goes up the operating room and tries, and it gets bleeding. He can't do it, and he ends up converting to a trab, which is his initial plan. But instead of just walking away with his tail and me doing his legs, he comes down, he's like, guys, you'll never guess what I tried, but I couldn't do it. And we're like, Ron, that is genius. That is amazing that you thought of that. We'll make this happen. And we learned from that moment because he learned from that moment. And Steve Getty showed this is the first patient that had GATT in the world. His name is David. And he came in, uncontrolled juvenile open-angle glaucoma. We said, you need a circumferential trabeculotomy. But we think we can do this. It's never been done before. We think we can do this without making a big flap in the eye. And you know what David said? Let's do it. So Ron and I sat down, we mapped out every possible permutation, and we did it. I didn't tell Ron at the time. That was the very first time I've ever made a goniotomy. We make a goniotomy. I'm passing the catheter. My heart is racing, and it comes around, and I pull it out, and I create the 360. I look at Ron. He looks at me. Our eyes are wide open, and we give each other a sterile fist bump. And it was amazing. But you know what happened next? David on the table said, hey, did you guys get it? Did you guys get it? So he was with us. And what's amazing is, the innovators get so much credit as they should, but we don't give enough credit to our patients. And David really changed the world, and he helped us learn GATT and spread GATT around the world. And this is a book, as Steve mentioned, of 26 chapters from people around the world doing GATT. So, what I've always thought about and what's instilled in me with GATT and Ron Fellman is a couple things. One, the founder of our practice was John Lynn, and he always said, our patients are our best teachers. Another tremendous giant in the field that was taken from us too soon, David Epstein, would always say, we're scientists in our clinical laboratory. And then Ron says, if you're not learning from your patients, you're not paying attention. And so, it got me to thinking about, we're practicing medicine. So what does it mean to practice medicine? Well, practice makes perfect, right? And we're trying to continue to learn, and we're trying for continual growth. But how do other professionals practice? So you see, like Kobe Bryant, he was the first person to show up to practice, the last person to leave. He had this perpetual instinct just to do his best. And he said, it's not about the number of hours you practice, but how much your mind is present. And Nadal, another great leader in tennis, said, I don't go to practice, I go to practice to learn something. And I think about what Djokovic says, it's like you should always try to be a better person today than you were yesterday. So, the AGS, what are we, right? I mean, we're the pinnacle of our field. We're the WNBA and NBA of glaucoma, right? And so are we practicing like professionals? And how are you practicing every day? How are you improving every day after every surgery? Are you reviewing your surgical techniques? Are you learning from your mistakes? Are you the best phacosurgeon you can be? One of the most instrumental moments I had was I grabbed my phaco rep, who'd seen hundreds of thousands of surgeries. And I said, Vince, I want you to help make me better. So a couple years ago, he sat in my OR for a week, tweaked my settings, tweaked my technique, and he made me better. One of the most instructive moments I had in the OR with phaco surgery. But are you the best tube surgeon? Are you the best MIG surgeon? What are you doing every day to be better? So I'll tell you what we're trying to do. So, what's next in MIGs? Well, we're constant, in 2013, on this platform at AGS in San Francisco, was the first time we introduced GATT to the world. And since that time, we're kind of being constant students of the angle and what happens to the angle after surgery, after angle surgery. And what we asked ourselves is, you see that trabecular shelf? Is there another way for us to create that shelf that mimics GATT, but maybe is a little bit less invasive? Can we just create a selective anterior goniotomy? And this is something that Murray Johnstone's dedicated his life to, and over the past 20, 30 years, this idea of motion-dependent outflow, where you have the scleral inlet valves, the Schlemm's canal inlet valves, the circumferential plexus, and this idea of a pump mechanism. And what happens in glaucoma, right? You get loss of elasticity of the TM, you get a stiffer trabecular meshwork, and the ciliary body loses its tone. Well, we came up with a surgery that we're calling, and Ron named this, the iVEnT, the Interventional Valve Enhancing Trabeculotomy. And we think that it lowers pressure using a unique spatula that we invented by creating a very precise incision in the anterior trabecular meshwork, just posterior to Schwabe's line, without damaging the valuable intracanalicular valve system and without obstructing the pulsatile nature of outflow. And this is what that spatula looks like. And here's an animation that shows exactly what we're doing. You sit temporal, as with most angle surgeries, and you have a left and a right, and you want to find Schwabe's line, and you want to just go just slightly anterior. You do not want to go into the canal. You don't want to disrupt any of the intracanalicular tissue. You make, in the non-filtering trabecular meshwork, you make a subtle incision, and you do that on the left and the right. And this can be titratable to 90 degrees, 120 degrees. We've done this in adults. We've done this in kids, too. And so let's look. This is kind of hard to get a good video of it, but I'm going to show a video of iVEnT. And you're going to see that I start with the left, and I'm pulling towards the pupil, and I'm staying as anterior as possible. You don't want to go into the canal. You want to stay as superficial, and I keep pulling posterior, and you don't want to keep passing over. You want to stay away from passing through multiple times, because you want to protect the endothelial cells, you want to protect the valves, you want to protect the beautiful nature of the angle. And you can go left and right, but you're not seeing bleeding. Right? You're not seeing any of this stuff because you're not being destructive to the intracanalicular structures. And I have one more video where I stained the trabecular meshwork with trypan blue. I want you to look nasal. Look at the top of the screen. You see that big aqueous vein, and you're going to see a nice episcleral venous fluid wave. Really a nice example that we're enhancing it. But you don't see the tremendous wave like we used to see with GATT 360 because I think it's less destructive. So here's hopefully a better way to visualize it, where again, you're making a very subtle, precise incision in the anterior, non-filtering trabecular meshwork, as helped visualized by the trypan blue. I'm pulling towards the pupil. I don't want to go into the canal at all. So I'm going using the left-handed one first, and then the right. So it looks all well and good, right? And the idea sounds kind of exciting. And this is what we think we see. We're seeing improved elasticity of the TM. We're seeing that the trabecular meshwork actually realigns and inserts more posteriorly. And we're seeing the scleral spur moving slightly more posterior. And I think we're seeing enhancement of the pulsatile nature of outflow. So here's an example, a lady who's 80 years old, 15-year history of glaucoma, pressures in the mid-teens on 3 meds. We do, and this is her pre-op picture. You can barely see a slit of Schlemm's canal, but you don't usually see much. But the post-op 1-month angle, we're seeing a slight dilation of the canal. And so we look at the nasal. We didn't do anything in the nasal, and you can see 3 months after the nasal, you don't see much change. But look what's happening based on different slices of the nasal angle. You're seeing different anatomy changes, dilation of the canal. But we showed this to Murray Johnstone. He just lost his mind. We lost our mind when we saw this image. You see this trabecular vent. The trabecular meshwork is curving inward to the eye. And you can see the incision of the iVEnT. You actually can see what looks like that white arrow is pointing to a Schlemm's canal inlet valve. And you can see that circumferential deep scleral plexus. It's 4 months out. And the thoughts on the mechanism of action, I think we're getting direct increased outflow through the trabecular, through that incision site. I think we're improving valve function. I think we're getting more flow into the distal collector system. And we think that we're getting increased aqueous flow through the trabecular meshwork itself. And that patient at 12 months out had a pressure of 11 on nothing. So here's another, this is another representation of the mechanism of action. But we're seeing multiple mechanisms of action, and we're seeing the scleral spur come more posteriorly. Almost what Murray Johnstone and we've been talking about with Ricky Wong is it's actually almost mimicking pilocarpine. So this is the same patient. Her right eye had a phaco iVEnT, but her left eye had a phacotrabectome by Ron in 2017. But look at the difference in the appearance of the angle. We've never seen an angle surgery do that before. It just blew our mind when we first started seeing this stuff. So yeah, this looks all well and good, but does it actually work, right? So we've done this in over 218 eyes of 144 patients. The vast majority of them had primary open-angle glaucoma. Vast majority were Caucasian, but we actually had 20% of our patients who were of African descent. And what's the stage of disease? About almost -6 mean deviation, the average mean deviation. So this was real disease. And what do we see? We saw patients go from 16 down to 13 at the 18-month period, and they went from 2 down to 0.6 during the same time frame. All right, and nothing's without complication. The way to avoid complications, you don't do glaucoma surgery. But look at the rate of complications. All right, hyphema rates, 9 eyes, 4% of these 218 eyes had a hyphema, a microhyphema or hyphema at 1 week out because you're not being as tissue destructive. And so this is a busy slide, I'm sorry, but this is, I think, what we need to start using, or maybe not this, but one of the ways to present our data after MIGS. So let me talk you through this. So the first column is the number of eyes. Second column is pre-op IOP, post-op IOP, mean IOP reduction, post-op follow-up, 18 months. And then we got pre-op meds, post-op meds, whether this predefined definition of success, whether they met it. But what I like about these last two columns is that this is the number of eyes on no meds and the IOP of those eyes on no meds. So let's just look at that second row, the patients that had pressures of over 18. Preoperatively, their pressures were 21. Postoperatively, they went at 17 months, their mean IOP was 14, and they went from 2.4 meds down to 0.8. But look down that line of eyes on no meds. Over 50% of our patients, regardless of the starting pressure, ended up on no meds, and their pressures were down in the low teens. And look at this low pressure group, right, the less than 14. They started off, we've actually made their pressure go up, right? They started off at a pressure of 12.3, and at 18 months, their pressure was 12.5. That's a failure in our old definition of success. We increased their pressure. But they went from meds from 2.29 meds down to 0.6 meds. And more than half of them had a pressure of 12 on nothing. So, conclusions on iVEnT. I think the post-op OCTs and the low IOPs are suggesting a novel mechanism of action. We think that this is enhancing motion-dependent outflow. We think it's valve enhancing, tissue sparing, safe, and it has a relatively low surgical learning curve. So, the classic definitions of success, I think we need a revolution, and that's the stage of next innovation, I think, for MIGS, is how we can truly define success. So, and Steve Getty and colleagues have done a great job bringing a committee together to define one way to define success in MIGS, and I think it's an amazing start. But there's certain ways where it doesn't capture success, and I call this clinical success, right? So here's an example. We have a patient with a pre-op IOP of 17, post-op 14. They go from 4 meds down to 1 med. That's not a 20% reduction in IOP. So that is a failure with the classic definition. Anybody in my clinic, I would love to have done that too. That's a huge clinical success. What about the next example? Going from pressures of 14 to 15, I increased their pressure, but they went from 4 meds to 0 meds. That's a major victory. Ron Fellman would give me a high five if that happened, right? But that's a failure because we raised their pressure. Right? So we need an innovative way to think about success after MIGS. And I think it needs to be transparent, maybe not that big busy table that we showed, but something like that. I think we need to have a reconsideration for when the pressures are low. And I think we need to really take into consideration pre-op meds. And I know there's this argument like, oh, well, you don't know how many they're actually using because you didn't wash them out. But I don't think it's ethical or practical in most clinical practices to wash out patients. And two, whether they're using it or not, my chart says they're on 3 meds. So whatever they're saying, they're on 3 meds, right? We know there's a compliance issue, but they're on. So I think we need some help in redefining our definitions. So, to bring this together, there's always room for growth. I aim to be better today than I was yesterday. And our patients are our best teachers, and our patients deserve our best, even when we fail, even if we fail. And we think iVEnT could potentially be the next phase in MIGS, and we need an innovation in the definition of MIGS. This is one of my favorite quotes of late, and I think about this every time I walk in the operating room, is that I don't rise to the level of my expectations, but I fall to the level of my training. And I think about that all the time. It helps me and motivates me to be better. And so ask yourselves when you go home if that statement is true for you. So I give a huge thank you. It's such an amazing honor. My parents here, my sister's here. So it's so nice to have my family here today. And my glaucoma associates family, I couldn't do it without them. They're my emotional support group. So thank you all for your support and your motivation to help us all be better. I've had just some tremendous mentors in residency and fellowship. Thank you for giving me this opportunity to speak to the AGS board and the members and President Siegfried. You've done just an amazing job this year. You carried yourself with intelligence and grace as you have your whole career, and you've done an amazing job and are an inspiration to us all, so thank you. She's also an amazing physician mom, but the most amazing physician mom I know is my wife, and I couldn't do any of this without her. She occupies a lot of the bandwidth that gives me the bandwidth to be a glaucoma geek. And without her ability to manage our lives and balance our lives, I wouldn't be able to do anything that I'm doing today. So she inspires me to grow as a person, as a father, as a husband, and a surgeon. And then my kids do the same. And they want me to make the world a better place. They inspire me to make the world a better place. So thank you.